Hello, good afternoon and welcome to the International Quality Forum here in London. I'm Domhnall Macauley, I'm the primary care editor of the BMJ, and we're here at a roundtable to talk about over-medicalisation, overdiagnosis. These are issues really close to the BMJ heart, and I have an international team here. I'll ask them to introduce themselves.
Thank you. My name's Rashad Massoud. I'm the Senior Vice President for University Research Company's Quality and Performance Institute in Bethesda, Maryland in the US, and I direct the USAID Healthcare Improvement Project.
Phillippe Michel, I am a physician from France, and I would like to thank BMJ for this roundtable, which is very core topic. I am currently a director for quality and safety in the second largest hospital in Lyons, and involved in several governmental working group on patient safety and over-medication for school.
Hello, I'm Jim Livingstone. I'm from Belfast in Northern Ireland. I have been a civil servant for many years. I recently retired. I'm now working as an independent consultant, and I have a psychologist as a background, so I'm very interested in the whole behavioural aspect of quality and safety.
Phillippe, let me come to you first, because this business of over-medicalisation and over-diagnosis, it really is an important quality issue. From a European perspective, what are your thoughts on this?
I think it was a quality issue. Now it's more a financial issue. I mean that the topic was largely handled some years ago, and now it's becoming a large issue because it is in the political agenda for financial reasons. But nevertheless, this topic cannot be handled without the quality and the safety people. So we are now launching a large program in France about appropriate diagnosis and treatment. Though this is coming back to the quality area.
And is that targeted mostly at primary care or secondary care, or how do you target
The Ministry of Health is targeting more the surgery, because it's the area where the largest output can be done. The largest economy can be done, and they have targeted in a second time the primary care on different issues, which is treatment. For example, we know that in France we have 40% of the people older than 85 years that take on a routine way sleeping tabs. And this is a large over-medicalization with a large problem of harm.
Yeah, I mean, changing that behaviour is going to be very difficult. Let's come to Jim in this. Jim, from a psychology point of view, how do you feel we should address this business, particularly in the sleeping tablets?
Yeah, well, I think we should start by recognising this is a behavioural issue. It's about an attitudinal thing, and it's both on the part of the general public, doctors, pharmaceutical companies. Somebody described to me one day as every new drug that comes on the scene is a miracle cure. Now, everybody wants miracles, and nobody is going to wait for the illness to cure itself, so to speak. And interestingly, politicians recognise that this is a big problem now from a finance point of view, but I dare say it's not spoken too much in public, because no politician wishes to be the politician who denies his or her constituents the miracle drug. And we have to break into that vicious cycle, that there is an issue about how new drugs are marketed, the attitudes in society generally that I expect to be seen tomorrow and I want a pill to cure it. And I think the antibiotic epidemic, for instance, that's been described yesterday, we're fast approaching a situation where the legacy that we will leave future generations is no antibiotics, because everyone has an antibiotic for a common cold. And if you think even in more recent times, there have been quite a lot of reports from GPs, patients presenting, men and women, presenting themselves to the GP looking for a pill to make them slimmer. So, in other words, instead of changing lifestyle, instead of changing behaviour and achieving that end at a very much less cost, but often takes longer, there's a pill that will do it tomorrow.
Rashad, I mean, you have a great international experience. I mean, you're involved with 30 different countries. Is this a big international problem?
I think it is. I think it's a global problem, and we see it both in the over-medicalization using drugs, but it's also the over-medicalization with diagnostic techniques, and even sometimes with procedures that are not necessarily needed. And all of this not only carries, it's not useful, but it's also potentially harmful, and comes at a great cost, like Phillippe said. I think, Jim, you're right. There is a psychological element here. People would like the miracle drug, but also I think there is an induced demand that is caused primarily through the triple role that the provider plays. They're the advisor, they're the ones who actually prescribe and conduct and do the procedure, but they also benefit from doing that. And I think we have to recognize this as a market failure in healthcare, and we have to tackle it from all aspects, the patient psychology part as well as the provider part. It's a very complex problem, and it is global. It cuts across economies. Back to your question.
Because you have great experience both in developing and developed countries. I mean, is it the same problem?
It looks a little bit different at times, but essentially it is the same problem. And to me, what's when there's a lot of money, maybe you can afford waste. I don't believe that, but one could argue. But certainly, when you're talking about economies that are not well enough off to be able to provide the right care, then anything that is incorrectly provided is essentially replacing something that could have potentially been a life-saving, and that's where it becomes a real problem. Countries that can least afford it shouldn't, that's where we should focus our attention. On getting the right drugs. Anything that's not necessary needs to be taken out in order to make best use of this.
Yeah. Now, you mentioned overdiagnosis, but let's think just about overtreatment for the moment. Phillippe, you spoke about sleeping habits. Any other examples we can think of that we think people are being over-medicalized on?
Over-medicalization, if you talk about surgery, it's over-treatment too. And then we have many fields where we know that there are a large variability between the rate of operation per inhabitant in different regions. And these are data that we have in all countries. Right now in France, we have the National Health Insurance that have the whole database of reimbursement. They know all about the variability, but they are not able to have an idea of the appropriateness, because that's a different thing. So they just put the emphasis on the variability, saying to the professional, look, there is a problem, now we have to tackle it. In the second time, the policymakers are coming and saying, look at the data, we will tackle the problem. We set it in the political agenda, and we have a top-down program which is in place. I think that's not enough, because the individual physicians won't necessarily change their habits with a top-down program. So,
just out of interest, can I ask you any particular surgical procedures that you think are a particular problem?
Amygdalectomy, prostatectomy, appendicectomy.
Yeah.
These very common interventions are all related with over-treatment.
Yeah. And in terms of getting the message across, do you have any trouble getting the message across to the surgeons? How do you create this culture where people are prepared to look at the variability?
The way to get the message to the individual physicians is to pass through the professional societies and associations. We have one successful story in France, which is not on this topic of over-medicalization, but which is on patient safety. Because of the high increasing cost of the insurance premium to the physician said that they cannot pay anymore. So the policymakers said, okay, we will take in charge part of your premium if you enter a patient safety program. And they gave to the professional societies the coordination of that. What are the learning points? First, you make people change if they can gain something. So where are the incentives? Right now, there is no incentive for to deal with over-medicalization, because we have a payment system which is they are paid to do more, not to do better. Fee-for-service payment, DRG-based payment in hospital. Everything is done to have more and more treatment and diagnosis. So this is the main point that has been tackled. Which incentive can be done? Anyway, the way to get the message is to pass through the professional societies. If they understand the incentive and the problem, they will act, and it will be successful.
Jim, I was going to come to you, Jim, because you have great experience of trying to change primary care behaviour.
Yeah, and I think in the past where people have set out to do that, the mistake has often been made is that I have to change him. I have to change the doctors, I have to change the nurses. When in fact you have to change the media. You have to change the patient and the public, all at the same time. There's an attitudinal issue to be addressed. And I think, unfortunately, governments worldwide are incredibly reticent about having that honest conversation, I would just say, about patient safety. They will advocate it in terms of their discussions, in terms of their planning, but they tend not to be very forthright about saying how many people die every year unnecessarily. And certainly over-medicalisation, as I said to you earlier, no politician likes to deny their constituent the miracle of cure. But that conversation between government and the public needs to be had, an honest conversation which talks about the cost, but also the health adverse outcomes because of over-medicalisation. So and I think in a public health context, where prevention is better than cure, that changes of lifestyle, that's not a message that goes down well. People don't like to hear, look, if you eat less and run more, you won't have a heart attack, or less likely to have one. People want the pill. They want, the treatment. They want the barrier surgery, whatever. So we have to have, I think, triangulation. We have a conversation between government and the public, and an honest conversation that is designed to actually, have a more realistic understanding of what healthcare is and what it can do for you. And then I think I agree with Phillippe that through the professional associations, I think the professions have to take a lead. I think they are the ones that actually have the greatest knowledge.
Let me come back to Rashad, because Jim, you talked about the harms, and particularly about the harms of in a sense, hospital and over-treatment. But there are harms from overdiagnosis as well, Rashad. Do you want to discuss those with us?
Well,
we'll not ask everyone if they've had their PSA checked, or but we can.
I think there are some things where screening is something we should be doing, and that can be actually very beneficial, if not life-saving. So those should be done. There are some things where the evidence isn't there, and those practices are things that we should really question whether we should have them or not. And so overdiagnosis, in a way, I mean, we could induce overdiagnosis as a profession, and I would say that we shouldn't be doing that, and we should be looking at where there is evidence for overdiagnosis or not. Wrong diagnosis is a whole other issue that leads to wrong treatment, and then we get into a whole other situation there as well. One of the things that I want to go back to is what Jim was saying, because I do think there's a role that we play as a healthcare profession. At the forum here just yesterday and the day before, there was a lot of conversation about social network theory. And I've been following this in the last couple of years, and I'm really intrigued at what is developing. Let me give you an example. Enrico Chiera, I think is the family name, was talking about the chances that somebody would be obese go up by 0.5% for every other obese person that they know in their immediate network. Now, so he was establishing the case for social contagion, and I thought that was fascinating. And then how do you deal with something like that? So there's a role that we play, but there's a role that we and patients and community can play, which is very different. And I don't think we as a healthcare profession have tapped enough into the social networks and how we can affect them. For example, he proposed something like a buddy system, where if you know you've got this social network of people who have a lot of obese people amongst them, then you can pair them up with buddies who are not, who would influence their behaviors. And if you actually dig deeper and find out who the influencers are in those systems, you can affect a population that way. I think I've heard Nicholas Christakis talk about this, and I think this is very much related to our work. I'd like us to sort of start thinking in that direction, in addition to what Jim was saying. I think there are some untapped resources.
There was a very interesting Christakis paper in the BMJ, and that was about social networks and happiness. So it's a Christmas paper a number of years ago about how we all live if we live in a happy social network, all our friends are happy. But anyway, let's get back to this overdiagnosis business, because I mean there is the problem of overdiagnosis. There's also the problem of overtreatment. But Phillippe, you wanted to come in there a little bit on the overdiagnosis.
I would like to comment on the kind of diagnosis, which is the screening.
Yeah. Okay.
So,
yeah.
Yeah, because I think that's a big issue right now, which is an ethical issue, a quality issue, and also a financial issue. We know that we have to increase screening of the population in many ways. But the question is, how far are we going into the screening? I want to take the example of Alzheimer's disease. The way there is a large discussion in France between the people that are thinking we have to put interventions as early as possible. So we have to put in place a systematic screening of Alzheimer's patient with Alzheimer's disease. And the other one saying that it's not sure that our interventions are so efficient. So we should wait to the early symptoms before doing the screening. And this is a huge difference. If we systematically screen all the people, we will have a huge amount of people that will have a further diagnostic, further treatment, without proved return on investment and also a return of outcome for the health. For the breast cancer, that's also a question that is raised. So in many screening activities, we should know to how far we want to go. And the question with the screening is also linked with the question of the criteria for diagnosis, which is not very far away. If we change the criteria of diagnosis and open the criteria, we will have a larger portion of the population that will go into the cascade of diagnosis and treatment. So these are questions that are directly linked to over-medicalization, over-treatment, and over-diagnosis that have been put together to find a solution.
Jim, yeah.
Can I just throw in another dimension, which is potentially controversial, but it's the pharmaceutical industry. They are a major player in all of this. Now, whatever chief executives of pharmaceutical companies might say, their first priority is to their shareholders. That's why they're in business. In other terms, yes, of course, they want to improve health. They want to contribute in terms of new treatments and new drugs and so on. But when you look at the marketing behaviour of pharmaceutical companies worldwide, and how it differs from country to country, because they attune themselves to the different political context, and you would almost think they're talking at times about a different drug, because they actually present it differently in different parts of the world. That's a major player in the whole, because they are influencing the GPs firstly, and then the consultants in the hospitals, and they actually in many cases are influencing the general public, often through the media. the number of stories that are about, by PR guys who are dropped into the media, they will ensure the public is aware of a new drug has come on the market before even the hospitals are aware of it. The story gets into the media and the public then say, I want that.
Yeah, so I mean, we have a major issue between media, government, civil service, clinicians, physicians. Let me come back to you just, because we're going to finish up now, to ask you for one thing you think we should change in terms of improving this whole business of over-medicalisation and over-diagnosis from your own perspective. So let me come to you first, Rashad, and see what do you think is a prime issue we should address?
I think I would go to the public. I think engaging the public in an honest conversation, as Jim was saying, would be my number one. And I would pursue that. I think that patients are rational decision makers. The problem is that they're often not presented with the right sort of information. We are seeing groups of patients who are very open about these, and there are patients who say, I don't want this, or my preference would be to manage it this way. So it is not a one-time solution. It's not, you don't press a button and it happens. I think we should regard this whole approach as a social movement that we can start, and I think key to its success is the engagement of the public in this conversation.
Phillippe?
I agree with Rashad, and I disagree. It's not my first, because it takes time to raise the culture of the public, and my first solution is also a long-term one, but so that's why I agree and disagree. It's the education of the physician, initial education and continuous medical education and continuous professional development, because we put more and more issues on underuse of treatment and diagnosis right now, and we have to add another piece, which is overuse of treatment. So I agree that it's quite difficult to give two different messages, but at the same time, but we need to deliver these messages, and so the continuous professional development must have as a priority over medicalization, which is a way to develop evaluation of practices plus education in a single way to decrease the over medicalization.
Jim, the last word to you.
Okay, thank you. That honest conversation, I think, has to happen. I do think actually that this is a serious enough issue right now, and it's going to get more serious as the years go on, that it should be something that's done on a global basis. No one government is going to take that step by itself, because the media and the public will be comparing them with other countries. But this is important enough for governments across the globe to actually come together and establish some sort of campaign to start having that honest conversation. Because that, if you don't define the problem in the public mindset clearly and unambiguously, then all the rest of it, you're going to be you're constantly beating your head against a brick wall. So define that problem, and I think if governments came together across Europe and America and Australia, and actually in a concerted way, start defining the problem in the public mindset.
Okay, well, we'll finish up there. We've had fascinating to have three different perspectives: a UK perspective, a European perspective, and in a sense a world perspective, and three different views on the solution that change the doctors, change the public view, and indeed change on globally. So thank you very much for joining us for this talk on overdiagnosis and over-medicalisation at the International Quality Forum. Thank you.
Thank you.